So we tried to really do it in a ooh-ah type of way. And to me, it may not be the most financially aggressive way to do things, but it sure is a lot of fun. And we really have a good time. Just to give you another example, if you've come across any of my patients in the area here, for the last 30 years, I shouldn't tell you this because other patients might pick up on this that haven't had surgery yet, but it's no big deal. I always give the patients an African violet or some type of nice plant with a photograph of me and the staff the next morning when they come back. So I've been doing that since day one, and I have no intention of stopping that. It's the little things that make this fun. Now, the surgery itself is very demanding. It's much more demanding in 2014 than it was in 1984. The techniques,
How so? I mean, what has really changed? Because from a patient perspective, okay, I read and I say, wait a minute, you're going to cut a 3mm slit in my eye? You're going to pulverize my lens with an ultrasound probe? I mean, all of these things did not endear me to the idea, but I go in, and the next thing I know, they're telling me it's done.
Mm-hmm.
So from a patient standpoint, I have to tell you, it seemed really easy to have cataracts done.
That's exactly right, and that's the way it should be. That's what we want. That's what we strive for the patient to say, quote, there was nothing to it. What goes on behind the scenes, so to speak, there's a lot to it. There's an infusion bottle with fluid going into the eye. There is this titanium pulverizer, if you will. There's a pedal at each of my feet, and there are monitors going, and I'm looking at so many things, and my assistant is handing me instruments. And so it is very challenging surgery. And the thing that's changed over the last 20 years is the transition to small incision, like you say, 2 or 3 millimeters, foldable lens implants. We now have bifocal lens implants. We have astigmatic lens implants.
Help me understand. When I did mine years ago, now, again, I have no clue. So a friend of mine was one of the head ophthalmic surgeons down at Walter Reed. He's my age. Old man I graduated, had ophthalmic surgeon for many decades. I called them, and I said, okay, I understand there's the plain old lenses, and then they got these fancy circular whatever it was that lets me see both far and close. Back in the old days, they told me, well, if you get the progressive or whatever you call it, the graduated ones, you'll have okay vision throughout. Back then, they both told me, pick. So I picked lenses that all of a sudden my granny glasses went away and I can see perfectly short.
Yes.
And I have to wear my glasses for long.
Okay.
Has that changed now, or?
Well, somewhat it has, and ophthalmology is a very equipment intensive and technology intensive specialty. It's some of the things we do now would have been truly science fiction 10 years ago. So you're asking about lens implants. When the cataract comes out, we have to put an artificial lens in. In my days, years ago, we didn't have implants. People wore those thick glasses called Coke bottle glasses.
Yes.
Then there was a period of a decade or so where contact lenses were used after cataract surgery, again, before implants. But people in their 70s, 80s, and 90s had a hard time with contact lenses. So Dr. Fyodorov in Russia, in the 70s, I guess, developed lens implants. And they were poo-pooed, they were criticized, and it was only the rogue ophthalmologist would do it, and we're going to damage the eyes and what have you. And it's been a lot of give and take over the years about the best way to, safety-wise, to approach this. But nonetheless, the use of intraocular lens implants is the standard of care these days. They can be made out of some form of plastic or silicone. They can be rigid. They can be foldable. Now, the most recent advent is what we call the multifocal. And that's in its infancy. It's in its development. I use them fairly often, but you have to be very selective in 2014, not what you may be able to have in your eye, and you would go, like you say, to the soccer game and say, well, Dr. Goodman put a multifocal and I can see far away and I can read the menu without glasses. Then you would say, well, why didn't he tell me I could have that? Well, because not every eye is amenable to that type of technology in 2014. maybe we can both sit down here in 5 or 10 years and talk again, and we'll look back and say, boy, that was really strange back then. Now, if you don't get a multifocal implant, something's, the surgeon didn't give you the best of care. So this is what makes it very exciting for me, and we try to educate people. That's the fun of it. I have medical students come through. I've trained dozens and dozens of other doctors over the years, and we learn from each other, and it's a wonderful experience.
So now, if I asked you fundamentally, to a sociology major, what is a cataract and why do I get it? Was I drinking too much? Was I smoking too much? What did I do to get cataracts?
It's a good question. I can't give you a quick, simple answer. Of all the options you just threw at me, certainly smoking would be number one to stop for any, as you know,
Well,
any
that's
number
for
of
any
reasons.
reason, yes.
But sometimes we see people in their 60s, heavy smokers with 80-year-old cataracts. But typically, we all tend to get them as an aging process. You can go through a list of issues that cause cataracts. Diabetes, diabetic patients more prone to cataracts. Anybody that's been on long-term steroid, cortisone use, whether it's a drop or pill or shot, cataracts.